you very much for these questions. So my research interest started actually in the 80s when I was a research resident at the University of California, Los Angeles, under the guidance of Gerald Buckberg. There we started to work on myocardial protection using blood cardioplegia, but also upon the field in modifying the initial reperfusate. And at that time, we were able to have the first surgical treatment for acute coronary occlusion after infarction. After I returned to Frankfurt in the 90s, we expanded this knowledge and treated acute leg ischemia, acute ischemic limbs, and we used controlled reperfusion for that purpose. When I became the chief in Freiburg, we continued this work by using controlled reperfusion for cardiac transplantation, and this was many times published, showing significantly longer ischemic tolerance to these hearts which were treated by controlled reperfusion. But also already in the 2000s, we started with multi-organ repair. So up to that time, we only use single organ repair, right, for the heart or for a part of the heart or for the legs, for the skeletal muscle. And now we started multi-organ repair for patients with cardiac arrest. And we call this treatment CAL, which is the abbreviation for controlled, automated reperfusion of the whole L-CAL body. And this was done in pigs. And we were successful in such a way that after 20 minutes, 20 minutes of complete cardiac arrest, the pigs were all neurologically intact, all meaning 90% were neurologically intact. And after this success, which was published in 2017, we started with clinical work. And just recently, we had a multi-center, 7-center European study using CAL for cardiac arrest patients with a survival which is 2 or 3 times as high as the normal survival, especially the neurologic intact survival. Current research projects are to use this CAL, to develop this CAL therapy further, also maybe for the field of the donation of circulatory cardiac arrest for organ donation. Especially, I'm working now for the improvements in the perioperative period called repair in order to achieve a much shorter perioperative period for the patients in the hospital. And there are new approaches to this. And one of these parts is that we are investigating the role of redox biology for surgery. Very much for this question. So I started doing cardiac surgery in 1981, when cardiac surgery was still extremely innovative and everything at that time seems possible. So, you know, heart transplantation, heart-lung transplantation, artificial hearts, ventricular assist devices, valve repair, aortic surgery, all kinds of congenital surgery. So it was really a fantastic time. And I was very lucky to find a very good working atmosphere at the University Hospital in Frankfurt. And I'm still together with these guys up to now. And I'm organizing a meeting every year with all these old OR nurses and doctors and whoever there is. And we still have much fun. And at that time also, it was obvious that there are shortcomings in cardiac surgery. For example, myocardial protection was at that time was not perfect. And one used even ventricular fibrillation. And the time frame which you could use for aortic occlusion was always very short. And therefore, research was, from the beginning of my career, always part of my clinical work in order to improve the options and the results for the patients. Yeah, thank you very much for these two questions. Maybe I start with the major breakthroughs first. And in my view, there are several major breakthroughs, and it's, in my view, also the perfect time for any young female or male surgeon to start in cardiac surgery, because cardiac surgery will definitely become a new field, and it will be different from the one we are doing right now. Why? Because first of all, there will be improvements in perioperative care, and that means we will work very hard to avoid any perioperative complications. And as I mentioned before, we are aiming to have these patients, even after major cardiac surgery, at home and discharged on day 1 or day 2 or day 3, and have a reduction in perioperative complications. Second breakthrough will be single and multi-organ repair. It's already in such a way that single organ repair is being done in organ repair centers. The cardiac arrest centers will be the centers for patients with cardiac arrest, and therefore both the fields of transplantation and resuscitation will change tremendously. As third point is, as we already know, xenotransplantation is now already being done, even though also we all know it's not perfect yet, but this is the normal way that in the beginning it needs improvements. This was the same in cardiac surgery for all the techniques which we have used, but I have no doubts that xenotransplantation will be done. The fourth huge area is robotic cardiac surgery. Robotic cardiac surgery will reduce perioperative complications. They are already much more advanced than 10 or 15 or whatever years ago. And they even have nowadays tactile function, and there are many new features. So robotic surgery will be clearly routinely done in a couple of years. Artificial intelligence, again, the next huge area, will change our field completely. It's already in clinical use. Patients are already informed about the operation by large language models, and there are studies out showing that patients do like that. It's not so that they want to speak with a surgeon, especially if the surgeon is not empathic or is not really knowledgeable about what's going on, which happens from time to time. Then they prefer definitely these artificial intelligence, but maybe we come back to this in a second anyway when we talk about ChatGPT-4. And regenerative medicine also will definitely change our field. Stem cell research has been done for many, many years. It was not very successful, we all know it, but fortunately, especially in Asia, researchers don't stop working. And if you're looking to the literature, they finally report some minor advantages, but I'm also sure that in 5 or 10 years, this will be definitely one of the main areas in research. So these were the breakthroughs. If we want to speak about ChatGPT-4, this is an extremely revolutionary and unbelievable option and opportunity for cardiac surgery. And I just want to make 7 short points and elaborate why this will change surgery fundamentally. Number 1, I mentioned this already, is patient information. Number 2, AI will help to make more accurate diagnosis when analyzing X-rays, CT scans, or MRIs. And this is also already routinely done today, not by us as cardiac surgeons, but for example, in urology. In urology, they already check MRI scans with AI. Number 3 is surgical planning. Surgical planning, meaning modeling of complex anatomical structures. This, for example, is being done in pediatric cardiac surgery, but on the other hand, also bypass and valve surgery and aortic surgery can be done like this. We all know that sometimes coronary arteries are difficult to find when they are intramurally or in fat or whatever. And now you can actually have the opportunity to preoperatively see exactly where the vessel is or what kind of valve problems there might exist in more detail. And for aortic surgery, if you have an aortic arch replacement, you can visualize all the intracranial vessels, and by doing so, you can reduce the neurologic complications tremendously. And surgical planning, but also for the optimal access routes for minimally invasive procedures. We can have aortic surgery with a small thoracotomy, but you never know if the aorta is really underneath, and so on and so on. So this can be really improved. Also, intraoperatively, there will be AI-controlled surgical robots for even greater precision, and they are able to support surgeons' movement, and there is even the autonomous execution of certain surgical steps. You might have heard that in Baltimore at the Johns Hopkins University, a robot has already done an intestinal suture completely by the robot himself without any help of any human being anymore. So this is clearly something which is being done. And intraoperatively, there is also the chance of have a real-time analysis not only for vital parameters, but also for the surgical technique itself and for immediate feedback to the surgeon. So we all know, you're doing your distal coronary anastomosis, but if this is filmed and analyzed, then the system, having data of more than 10,000 of these kind of operations, know exactly what's going on, and they can give a feedback to the surgeon. Number 5 is, of course, training and education. So realistic surgical simulation to practice complex procedures is already being done. The same as to train airplane pilots. So the same can be done in our specialty. And these training and education tools can be based on the surgeon's individual progress and weaknesses. And AI can even develop customized, personalized training program for surgeon A, B, C, and D, because they all have different strengths, but also different weaknesses. And there you can train them. Number 6 would be post-operative follow-up. That means to analyze the post-operative data to detect complications at an early stage. We all know that kidney failure or renal insufficiency is better treated the earlier you start the treatment. And this would be, of course, fantastic, but also to improve the medical treatment with these multiple drugs on the ICU. Again, this is being done. I know centers who are using this already, because especially drugs on the ICU, they have 20, 50 side effects, and they might interfere between each other. And this is very difficult to see all the time for the doctor to see, what kind of interference there might be. So this could help us. And lastly, research and innovation in surgery. So AI can analyze large amounts of data to gain new patterns and insights, but also to improve current techniques. So all this shows that we are really at the dawn of a completely new era in cardiac surgery, and therefore I welcome all young guys to join our profession. This is also for, of course, young surgeons, but for everybody, very important question. So major challenges are numerous during my career, and one has to know that this is normal. That's always how it is. Nowadays, one gets the impression that one tries to protect the children from all problems and complications, but this is the wrong training, so to speak. You will face many problems in your life, full stop, that's it. And therefore you should train this early on. And because this is the rule in life, to face problems, you have to find a mentor soon and early. And so, as I mentioned before, I was very happy and lucky to have found clinical mentors in Frankfurt. And this was, of course, great, but you need somebody. That's what I mean. You need somebody. And you also should find a research mentor. And there again, I was very happy to have found General Buckberg in Los Angeles, a famous cardiac surgeon at UCLA. And finding such mentors is almost always a series of coincidences that are almost impossible to predict. So it's hard, to really give some advice, because sometimes at the end, after you have found somebody, you know that there are so many steps which were unpredictable before. Next one is that you have to learn to prioritize your task and the time. That means you cannot do everything. And many people have great ideas, but the execution of these ideas is not perfect. And they are losing time. They are engaged in hundreds of different purposes, and that's not the way it should be. So prioritize your tasks and the time. And the last point I want to make is you have to cope with setbacks and develop resilience. There is always a long period of trial and error. And if you ask successful people, whoever you want to take, ask them, they all tell you that they had more failures than successes, even though you only remember them for their successes. But a failure is a normal step in your career. I mean, all your questions are really very well formulated, and this is also very interesting. Very good question. So, young medical professionals. Number one, the overriding topic is attention to detail is the most important thing. Attention to detail. And that means you have to solve problems independently and take responsibility for what you do. You should not blame others for any of your own failures or mistakes. Not blame any others. Take responsibility and just do it. And the third point is what I also told my residents when they said, what can I do in order to become a better cardiac surgeon? I told them, you can train surgery by all tasks that you have to accomplish anyway. And this is garden work, music, craftsman's work, or whatever, because it's always the same rules. The rule is pay attention to detail, make it perfect, even though you are only working in the garden or whatever you like. I have no idea, whatever. Make it perfect and not just do something. And second, if it doesn't work, don't blame others. I mean, then you just have to improve. So this is number one. Number two is now what's quality and skills are most essential. There are these famous 3 A's. I don't know if you heard about it. The 3 A's are be able, and that means, of course, I mean, you have to do surgery. I mean, if you're completely unable to do surgery, that's a problem, right? I mean, so you have to be able. Second, be available. With 3 days a week, I tell you, it will not work. As simple as that. So be available, because there are always emergencies, always problems. You have to be available. And the third part is be affable. Be a friend to everybody. Don't fight with everybody. So be able, be available, be affable. And the last point is getting more and more important, namely, in your life, you have to find a partner who agrees to your lifestyle. Let's assume you work like crazy because you love it and it's what you would like to do, but your partner hates it when you come home at 9 o'clock in the evening. And then you have a problem too. You know what I mean? So it's a whole field. Be able, be available, be affable, and find a partner who likes that and who loves you despite the fact that you're not very often at home. That's okay.